Diverticular disease. Etiology, pathophysiology, and pathology. Although there are suspicions that there may be an underlying genetic predisposition to diverticular disease, it is best considered as an acquired condition. Diverticuliform is herniations of colonic mucosa through the muscularis layer. This process tends to occur more commonly in the distal colon and usually occurs at the point of entry of penetrating blood vessels through the muscle layers, hence the presentation with acute hemorrhage. Epidemiology. The prevalence of diverticular disease of the colon increases with age. It is present in 50% of the population over the age of 50 years. Clinical presentation. Common. Diverticula are common in elderly people, often asymptomatic and regarded as an incidental finding at colonoscopy and barium enema. Acute presentation is usually in the form of one of the common complications. Diverticulitis, an associated inflammation of the colon, often related to infection and thought to result from impaction of feces within a diverticulum. Colonic bleeding, a frequent presentation of diverticular disease, thought to result from the fact that diverticula form at the point of maximal weakness in the colon, i.e. at the point where blood vessels penetrate the muscle coat. Some patients will have nonspecific symptoms such as low abdominal pain, constipation, or diarrhea. Uncommon. Diverticular abscess. Colovesical fistula. Colonic stricture, after repeated episodes of inflammation, resulting in subacute colonic obstruction. Physical signs. There are no specific physical signs of diverticular change itself. In acute diverticulitis or in the presence of a diverticular abscess there may be left iliac fossa tenderness or a palpable mass. Investigation. Barium enema and colonoscopy. Diverticular change may be demonstrated by either barium enema or colonoscopy. Abdominal CT. CT is the best way to demonstrate abscess formation, Fig 56. Colovesical fistulae require a high index of suspicion, recurrent urinary tract infections, pneumaturia, etc., but may be identified on barium contrast radiology, Fig 57. Differential diagnosis. This includes colonic carcinoma, colonic ischemia, inflammatory bowel disease and irritable bowel syndrome. Treatment. Short-term. The management of diverticular disease is determined by the extent of symptoms or presence of complications. Acute diverticulitis requires intravenous fluids, antibiotics, and analgesics, with diverticular abscess often requiring drainage in addition. Bleeding will usually settle with supportive treatment. Long-term. Avoidance of constipation, high-fiber diet, bulking laxatives such as Normacol, and good fluid intake, is recommended in the belief that this may reduce the risk of complications. Surgery is reserved for complicated diverticular disease, i.e. bleeding, abscess, stricture. Prognosis. Many patients experience recurrent diverticulitis or bleeding, but diverticular change is not a progressive pathology and there is no increased risk of colonic neoplasia.